I'm Joe Morrison with Right2Breathe, co-founder and CEO, and we're fortunate to have a great group of folks with us today. Do a quick introduction of some of the board members that are on the call. Of course, John Linnell, Allison Morrison, and of course, Michelle Da Silva, who is our Director of Education. We are so excited to have Dr. Kreiner on the call from Temple Health, as well as, three patients, Paul, Ronnie, and Leslie, to speak about the Spiration valve. Guys can take it away. Actually, Dr. Kreiner, by all means, you have the floor, sir.
Thanks, Joe, and hello, everyone, and thanks for the privilege of being able to talk to you today with three of my patients. And I think what it's important to do is to show additional patients that have had bronchoscopic lung reduction with Spiration valve system, and this builds on a discussion, I guess, that was held about a month ago with Dr. Hogarth from Chicago, where some discussion was had about the use of Spiration valves in bronchoscopic lung reduction. We think it's important that patients hear different perspectives, and they actually hear it from patients who have undergone a procedure like this, to learn what the indications are, what the benefits are, how long it lasts, and really what the complications are, to be upfront and really have a frank discussion about it. I think when you go through sessions like this, you might think that everyone will have an outcome like these three patients did, and how important the valve was to create that improvement that they had. But all patients are different, and some of the benefits that patients have aren't just related to a Spiration valve or any other valve. It's related to the whole construct of COPD care, which many of you on the call know what that is in terms of rehab and oxygen and using your medication. So it's one feature of that. So that's the disclaimer, that all that you hear over the next hour may not just be from the valve, and not everyone gets the same response. So that aside, the most important thing is to meet the patient. And I'm going to have Leslie, Ronnie, and Paul introduce themselves. Let's start off with Leslie. If you want to just go give you an introduction of where you're from and how long it's been since you received the valves. Leslie?
Okay. Thank you, Dr. Kreiner. Can everybody hear me? I think I'm unmuted now, right? Yep. Okay. So my name is Leslie Kronberger, and I live in Somers Point, New Jersey. I received the valves 4 years ago, October 21st of 2016. And thank you for joining this call, everybody, and for inviting me to be part of it.
Ronnie?
Yes, my name is Ronnie Neal. I live in Germantown, Philadelphia. I had it for 3 years, and it's been doing great for me.
Paul?
Hi, my name is Paul Goldbeck. I am from near College Park, Maryland. Dr. Kreiner just recently installed 4 valves in my left lobe in August of this year.
Good. Well, I think one of the most important things is to really discuss what made you. I know Ronnie and Leslie, you both joined the IMPROVE trial, and Paul, you had it as post-approval for clinical care. But what was the most important symptom that each of you had that made you decide to do something in addition to optimal medical care? Ron?
Well, it's having COPD is tough, and if it's some type of improvement it can have for your lungs, I want to try, but I want to read as much as I can on it. And I know I came aware of this like maybe a year or so before I had the procedure, and I just wanted to do some of my research myself. And then it came around again where it was in a trial area, and I had it done, and I never looked back. It was just a great procedure for me.
Good. Hey, Leslie, what do you think?
Well, I first heard about the valves through Dr. Kreiner, and initially I wasn't sick enough to make it for the one trial, but I was interested really right away because I knew how my disease was progressing. I have grandkids. I couldn't do a whole lot with them. Sometimes it was hard for me to just walk out to the car. And so once the the opportunity came, I pretty much jumped on it. And since then, I've been able to, I was never real athletic, but I walk on the treadmill almost every day. I can push myself more. And I feel a reward from that. I mean, I'm not going to go play basketball, but I can go walk to the beach. I can push a stroller. And actually, along the lines of the biggest thing, as I mentioned, seeing my grandkids and playing with them was huge for me. So the following spring, I had the vows in October, and at Easter, I had never been to Disney World, and we went to Disney World. My husband and I took my daughter and son-in-law and their three kids, and I thought I was going to have to ride one of those carts, and we rented it for the first day. My husband rode it, and I walked the rest of the time, all the days in the park.
Wow, that's great.
Yeah, so I feel like I owe my Disney World to the vows.
How about you, Paul?
I guess I noticed my problem 4 or 5 years ago. Didn't do anything about it except just go visit pulmonologist. And the big thing for me was I wanted to mow my own lawn. I wanted to be able to go out in my gardens and put flowers in. But I couldn't do it. I was just losing my breath. My breath was going away fast. I also do major displays at Halloween and Christmas. And frankly, without this valve, it would not have happened because it's just too restraining. I have to stop too often. So it has worked wonders for me.
So I guess it's safe to say that all three of you, the major issue was being short of breath, and short of breath mainly with exertion that limited your activities. Is that fair to say?
Yeah, that was the biggest thing with me because you just try to do some of the basic things of walking up the street, walking up the stairs, and you get out of breath so fast, and it's irritating, and it's, you just want to see if you can do more. But well, when you have COPD, you got to learn how to change your lifestyle. But when I got these valves, I was able to walk further. I was able to do more things around the house. And then sometimes you sort of caught yourself saying, "Gee, I normally used to be out of breath when I used to walk 2 blocks." But now it's a good thing for me. It's a great thing, actually.
If I may, the other thing, Ronnie, I think you'll agree with this, that goes along with being so short of breath is the anxiety
Yes.
that you feel.
Yeah.
And it just adds to your shortness of breath. And for me, there was an awful lot of embarrassment that went along with that. And especially as an ex-smoker, I felt like, oh my gosh, this is absolutely awful. Everybody's just going to point a finger and say, I told you so. And so that psychological element, if there's anything that helps you to do more, you can oftentimes learn to control your anxiety a little better because you know you can get there. You know you can eventually breathe again.
Yeah, anxiety is a big thing because sometimes you used to go outside prior to this procedure. They said, "Can I make it here? Can I go shopping? Can I do this?"
Right.
And you just pace yourself and you can do these things. But it's now with the valves. Now I'm confident going out, going grocery shopping. I'm confident going out and doing things I have to do. Even prior to this COVID-19, I go travel up to Connecticut. And prior to that, it was just so difficult with suitcases and things like that. Everything took so much energy out of you. But now you learn to live with it and you got these valves. My life has changed around so much. I'm just so thankful for it.
I'm glad that I could actually sleep because when I laid on my side before the operation, it felt like something pressing against me. And then if I got up, I was completely out of breath. If I went to the bathroom, I'd be completely out of breath. Now I can lay on my side. I actually can get good sleep for a change. And I can lay on my back. I can lay on either side. Getting up, going to the bathroom doesn't bother me, although it's frequent. It's just a fabulous turnaround. And they're right about the anxiety thing. it wears and tears you down bit by bit, not a lot, but bit by bit, until you feel like, why am I doing this? But I feel so much better now. This is just wonderful.
So, Paul, you touched on it, but a lot of the patients that you see for the first time when they come in to talk about contemplating lung reduction, they want to know how much better will I feel and how long will it last. So can you guys just give a little bit more detail about how much better do you feel post compared to pre? And at least Leslie and Ronnie, how sustained was the effect? How long was the benefit?
Say it again, Dr. Kreiner.
So how much better do you feel after having it done compared to how you felt before? And how long does it last?
Well, I feel better now because I have a regimen where I used to go to a gym, and I noticed I can almost double what I used to do before. I used to like grades only to like 3, but after the procedure, I was go up to grade 8, and I hold it for 2 minutes, and I knew that is something special for me. I was able to work out more with weights and things like that, and I noticed like my distance, I can walk further now. And when I first had the procedure, I got home. I want to say maybe like 3 to 4 days. I was starting to feel because I know I live in this block, and for the past years I've been walking, and sometimes I'll stop once or twice till I get to the corner. And it must have been like a week after this procedure, I walked all the way to the corner. I'm sort of standing there and almost going to scream because, oh my goodness, I'm not out of breath. But
Yeah.
that's the biggest change I know, that I can walk further. I can do more things when I go to work out at the gym. And it overall, it gives you more confidence also. That's what I notice about me.
Good. Leslie or Paul, do you guys want to comment on that?
Sure. Paul, I can wait for you.
No, you go, ladies.
Okay.
Beauty before age.
Okay. Okay. Thank you. So I still feel better than I felt before I had the valves. It's 4 years. I do walk. I work at a desk all day, so I have to push myself to walk. And I never enjoyed exercises, but I enjoy walking on the treadmill now because I can do it. Now, I'll be honest, if I'm walking fast, if I'm going at 2.5 miles an hour, which is very fast for me, would have been if I had good lungs, I'll use 1.5 liters of oxygen to do it, because then I can do it for 30 to 45 minutes. I can do almost 2 miles at that pace without stopping. So, and it was pulmonary rehab and the pulmonary lab at Temple that explained to me the last time I had my PFTs done, use it, because you need to keep doing it. So that's the one thing related to the length of the benefit. I still feel better. The other thing was, and I've just only recently realized that this is a tell for me. For a long time, a number of years before I was formally diagnosed with COPD, which I knew in the back of my mind that I probably had, I would feel a painful band around my chest, where it just did not want to expand. And now, if I'm coming down with a little something, or if my allergies are bad, or like I have an element of chronic bronchitis also, and I have some asthma, if any of those things are starting to flare, I get that band again. It tells me, drink some more water, do an extra nebulizer treatment, take your temperature, but it doesn't tell me don't walk. I'll still walk, maybe not as long that day. So that was something that I noticed got better with the valves. So now when it comes back, I know I'm just, I'm not in a real good spot with my disease. I have to take care of some things.
I can't walk like these two can. I have other issues in my legs that is not related at all to my lungs. But I can bike, and I do bike 4 to 5 miles a day. This is outside on a road bike. I can take it easy. I can do stuff around the house now, including bending over, tying my shoes, putting my shoes on, where before I'd be completely out of breath. I would be completely out of breath. I have to go downstairs to do my laundry. And since I do it like every 4 or 5 days, I have to go down those steps and come back up multiple times. I used to get out of breath frequently, but I don't do that. It's not happening anymore. I feel so lucky to have found this. It has made my life completely different from what I thought it was going to be, and also prevented me from potentially seeking a lung transplant, which I didn't know whether I would have fell into that category or not. I just felt miserable. Now I feel great. Life is good.
So it seems like all three of you really emphasize the importance of being physically active on a regular basis overall. How key is that to the outcome that you guys had, do you think?
I think it's important just to stay active, because I was doing some working on the gym prior to this, but I think it's really important just to stay active. And I always say this to people who have COPD or base people: you don't have to be in a big gym or anything. Get your loved one and walk up to the corner, walk around the block. Some of the basic things are just walking is good cardio for the body. And I just think to me, I think it's important just to stay active, because when you don't do things for a few days, and you start, your body's
You feel it.
you start to know that your legs and your chest. I think it's really important just to stay active.
Go ahead, Leslie.
Along those same lines, Ron, I found that going actually to pulmonary rehab
Yes.
was really a good thing for me.
Yes,
It not only, I didn't know how to exercise, and so not only did it familiarize me with the weights and all, but it gave me a network. There's no way, even to this day, that I would ever go to a gym. I'm not a gym person. I wouldn't
Right.
fit in at all. I wouldn't even know how to lift the things. They'd be saying, get that lady out of here before she breaks something, But when I went to pulmonary rehab, I met people. I didn't feel so alone, and it was great. And actually, I kept going. It's only since, I guess, last year in the fall, I stopped going for a bit. I was dealing with some other things, some reflux issues and stuff like that.
Mm-hmm.
And I was going to go back after the last time I saw Dr. Kreiner, and then COVID hit.
Yeah.
So fortunately, I have this, I have my treadmill, and I walk on that. But I do miss all the folks there, and I can't stress enough that a pulmonary rehab, whether you got valves or not, is really pretty much where it's at. You learn from other patients, and you don't feel as isolated or alone.
Right. And it gives you confidence to go out in the world.
Yeah, it really does. It really does.
I found that self-motivation works for me. Pulmonary rehab did not work.
No?
Maybe it was just too light. I would rather push it. They didn't want to push, so I left. But I started riding the bike.
Mm-hmm.
I'm doing a lot of walking around I'm not walking for distance. I'm walking to extend myself, to try and build myself up. I have noticed it's a lot easier to deal with everyday life, which is what most of us have to deal with. By having this operation, not wheezing anymore, I'm breathing a whole lot easier. It just seems, I don't know, it's like a whole new world has opened up, and I'm very grateful.
Yeah.
You count your steps every day?
No.
Sorry, excuse me.
I don't
No.
want to give that kind of a goal, Leslie.
No, you don't.
I know how long it takes me to cycle around a circuit. I know some days I don't quite make it the extra time, but most days I do, and I can just relax.
When I first came home from the hospital for my valves, that's what really kept me pushing. I walked up and down, paced back and forth on my porch. My neighbors must have thought I was crazy, but I had a pedometer on, and I wear it every day.
Oh, that's great.
And I was like, okay, I did 200 steps. I did 500 steps. That's what I did. Everybody's different, but whatever it takes. Sorry,
Good.
I didn't mean to interrupt you, Dr. Kreiner.
No, it's perfect. Interrupt me anytime.
Excuse me a second.
One of the things I think it's important for other patients to talk about is the procedure itself.
I'm busy. I am very busy.
Were you scared? And
Uh,
what was it like to undergo the procedure?
the procedure, I mean, I guess anytime you're going to go through a procedure like that, you're a little nervous, and things like that. And the doctors, they explained it to me from A to B, what's going to happen, things like that. In the day of it, I don't know how long it was, like 45 minutes, an hour or something. I had a small amount of discomfort, that's in the throat. But outside of that, I felt fine.
Good. How about you, Leslie?
Well, I was very excited, but I was anxious too. I wasn't really afraid. I'm a nurse, so I really feel like I know more than I know. I'm sure, but truth be told, but I was anxious. I was every now and then a little thought would come to my head, like, what if this happens or that, and I kind of pushed them aside. But I had some known complications that happen anytime you do anything with the lung. That being said, the care I received was wonderful. I came through it with flying colors, and I even walked like with 2 chest tubes in. Physical therapy, pulmonary rehab. They came in, they helped me walk up and down the hallway of the hospital. But it was challenging while I was there. Because I was scared, of course. I wasn't expecting, frankly, I thought I was going to go in and, like you described, Ron, although I know you were in for a little bit too, I'd be in there 2 to 3 days. I brought a book. I bought myself a new sweatsuit. I thought I was on a little mini vacay, it was not that way.
I bought my iPad and my phone. They have a secure network there. It helped get me through. Rather than watching their TV, I could watch my TV. I had also a pneumothorax. They had to put a tube in me. I was in the hospital for nine days. None of which, after the first initial day, did I hurt. I don't remember being hurt. They actually had to go in and make the tube larger because it wasn't sucking out the air like it was supposed to. So they put a larger tube in. I was awake for that. Not the first time, but the second one I was awake. And those people are gold. The nurses, the technicians, the CPRNs, everybody was just fabulous at Temple. It is a fabulous system, and Doc, we have Dr. Kreiner to thank for that, for setting that whole floor up for just lung issues. And it's amazing to hear the nurses and how they're talking. And, oh, you're fine, you're fine. And they'll come in and check on you in a second. So it's not like it is on a regular floor where maybe you might see them once a day. No, you get to see them at least once an hour, probably more than that initially. I enjoyed I was a long way from home. There was nobody not that they could come visit me anyway, but it isn't like I could pick myself up and walk out the front door and take a bus home. The people were fabulous. Everybody there was great to my family. I can't say much about this. Is just the most perfect surgery or procedure that I've had in a hospital.
Great.
So some patients ask, do you feel anything in your chest after the valves are in place? Do you feel the valves? Do you feel them move?
I don't.
Place or anything?
I don't.
I don't at all, Dr. Kreiner. I couldn't feel anything when it was put in. I couldn't feel anything during the pneumothorax thing when they were moving things around and trying to get the lung to inflate, which it did. Everything that was supposed to happen happened, and when I got home, I felt great. It felt like nothing had actually had been done, and I think a lot of that is because there was no incision, except for the little hole in the chest. There was no incision. There was no major lung surgery. and you recoup faster than that.
Good. Does anyone want to say anything else before we open it up to other people on the call? So anyone can ask you guys questions. Is there any other comments you'd like to make, Ronnie or Leslie?
No. I think I said it. If something comes up, I'll get it off.
Got it out.
Me too. Me too.
Joe,
I'm not shy.
Yeah. Joe, you want to open it up so anyone can ask a question?
Dr. Kreiner, if I
Sure.
could,
Go ahead, Leslie.
Go ahead.
I would just add to about feeling the valves. I would agree that I don't feel the valves ever. But one thing I did have, and Dr. Kreiner had explained to me about this, I had some discomfort, that area of the lungs, there's so many, there's such a supply of nerves there and your rib cage. So I did for a while have almost like an arthritic type pain. Now I have arthritis, and when it gets cold, I feel things, but I've never to a point where I've had to take anything for it. If anything, I put like a little bit of Aspercream or something on it, or a heat, or ice, but not on a regular basis at all. But, I just wanted to mention that. But as far as feeling the valve itself, no way.
Good.
You don't feel valve.
Okay, Joe.
Yep. So we have a number of questions in the chat. So I'm going to kind of fire off a few of them as we go. So first from Jan was a question really to the patients, and then Dr. Kreiner, you may be able to answer this for some of the other folks that have had the procedure that are not on the call. Was anyone having frequent exacerbations? So I don't know, Paul, if you want to speak first, and then go to Ronnie, and then go to Leslie.
Probably so. Before, I would be on my regular emergency inhaler, my albuterol. I've used less now than I used before. And the exacerbations before were awful, and they would come 2 or 3 times every couple hours, where now I'm getting it like once or twice a day.
Got it. How about you, Ronnie?
Well, I noticed with exacerbations, and basically, I don't know where it's the same thing. When I used to catch a cold, like normally like once or twice, you'll catch a cold during the season. And my goodness, they're just so horrible because you have all this mucus in your lungs and you can't really breathe that well. Now, after I had this procedure, it almost seemed like a common cold. I still get it, but I'm not so beat up as I were before. Because after I had the procedure, I could still get around. But prior to that, when I got sick or some exacerbation, oh my goodness, I could barely do anything because you're just so
Right.
you're just so beat down with it, And so
Absolutely.
I have a better quality of life now still, also.
Got it. Thank you. Leslie?
Yeah, so before the valves, I was having a lot of exacerbations. I remember saying to Dr. Kreiner one time, "Oh my gosh, I feel like I'm always having an exacerbation." But after the valves, that did seem to decrease, and my exacerbations are the worst part about it is the steroids, where it used to be the worst part about the exacerbation was, as Ronnie described, the congestion, the coughing, the shortness of breath. Now it's just the steroids that make me dizzier than I normally am, more nervous and jerky than normal. But they have decreased.
Got it. So, Dr. Kreiner, do you see that regularly in patients that they seem to be having a lot of exacerbations, and then would that actually potentially disqualify someone? Can you be having too many exacerbations? And I know that is a wide open question that there could be any number of reasons for those exacerbations. So I know I'm kind of throwing you a almost an unanswerable question, but please go ahead and provide what input you can.
So some exacerbations are mainly manifested by being short of breath, and pretty much if the shortness of breath is related to hyperinflation, lungs being too large related to advanced emphysema, then if you can sort out other things that may lead to an exacerbation, such as like a lot of mucus or a lot of reactivity to like allergens, which valves won't help. You can choose and select a patient group that may have benefit by decreasing exacerbations if they're breathlessness or dyspnea driven. So if you look at the NET trial, lung volume reduction surgery, looked at exacerbations the best because that study was larger and longer than any other study. And what we found is over the 3 years of the analysis that we did, that exacerbations post lung volume reduction surgery was decreased by about 30%. In some of the larger bronchoscopic valve trials, we've seen a trend towards an exacerbation reduction after a month after you have the procedure, because the procedure itself can increase the risk of exacerbation just because of doing a bronchoscopy. But we would expect you have effective lung reduction in an appropriately chosen patient where dyspnea is driving their features of their symptoms. The patient should have less exacerbations also.
Got it. Got it. And I actually got to apologize in case there's somebody on the call that is unfamiliar with the term exacerbation. Probably 90% of you or better are, but just in case, it really just means a sudden flare-up of your COPD symptoms or a worsening of your symptoms. Sometimes because I've been around this for so long and caregiver for my dad before he passed away, I've gotten so used to just throwing terms around and not thinking twice about it. So apologize if anyone is sitting there scratching their head going, all right, you lost me. So okay, so we got a bunch of questions coming through here. So let's see. So following up from Jeannie actually had two questions. Were any of you, or was anyone using oxygen before the valves, and can lungs be too damaged to be considered for the valves? And she says an example of an FEV1 of 16% of predicted.
I didn't use oxygen before, and I couldn't answer the second question.
Right.
I wasn't using it.
Got it. Ronnie or Leslie, were either of you guys on?
I use oxygen just to sleep with. I have a Trillium I use that to sleep with.
Leslie?
I wasn't using it before the procedures, and I don't use it regularly now, but I have it. I won't let them take it out. If I don't feel well, I might use it at nighttime, and I use it when I exercise. If I'm going to really walk, I use it to keep me walking. I couldn't answer about an FEV, but I know that there is something about you have to have a sealed fissure, so that you can collapse the one, and Dr. Kreiner will talk to you about that more. But that's all I know as far as, I don't know that you would be too sick necessarily.
Right. That obviously that second part really was for Dr. Kreiner more than anyone
Yeah.
else. So.
So let me take the questions one by one. I think there's two. One, does this improve or reduce your need for oxygen? And it can in a small percentage of patients, about 15%. But don't do this procedure because you think you're going to get off oxygen, because what it does is decrease air trapping in your chest, which makes you less short of breath. But it doesn't improve functional lung tissue. It's a adjunct to your treatment. It's not a cure. So that's the first thing to remember. Don't go into this thinking that it's going to improve your oxygenation, because it rarely does. The second part of it, can you be too sick for this procedure, or can this procedure not be right for you? And both of those answers are yes. What patients should do is go to a place that just doesn't do one treatment for COPD or emphysema. They can offer you a range of different options to improve your outcome, if it's change in medication, or if it's a change in non-pharmacologic treatment, like you need oxygen, or you need rehab, or you need all three, or maybe your anatomy. Leslie brought up the fissure. The fissure has to be intact. That's the normal separation between the lobes in your lung. You have one on your left lung and you have two on your right. And if those lines aren't complete, a valve will not work. But surgery may. And lung volume reduction surgery is as effective as a valve is in an appropriately chosen patient. And it's Medicare approved. It's been approved since 2004. So people should keep that in the back of your mind. And yes, lung transplant is a viable option in some patients. That valves are an interim or a bridge therapy for some patients. It's a destination therapy. Nothing else is needed in others. But lung transplant may be something that people who have too severe disease might be appropriate for and take advantage of. So it's important to seek options. Go to a place that's knowledgeable, that basically has a variety of different ways to treat you to make you feel better.
Great. Excellent. So our very own John Linnell has a couple questions, and I'm going to kind of throw them together. And this really would be directed at Dr. Kreiner. So John writes, is it an operation or a procedure? While invasive to a point, there are no incisions. That's the number one. And then the follow-up to that is, what are really the parameters required, or how do you qualify? And I think you answered some of that just now, but if you want to expand on that just to touch, those were John's questions.
Well, I'm not answering any question from John unless he does that thing with his hair again. That was like the best thing I've seen all day. It's terrific. That made my day, John.
Thanks, John.
So, two good questions from John as usual. First of all, it's not an operation. There's no incision or cutting, but any procedure can cause complications. So I don't want to minimize that things can go wrong if you don't choose the appropriate patient and you don't choose what part of the lung to put it in. So I don't want to minimize the chance that even a minimal procedure can. So, you really need to think long and hard about where you go. Ask a lot of questions when you go. I think all of my three patients there, they're pretty much could be deputy pulmonologists. They were well informed and well versed and knew what to expect before they came in. They asked a lot of questions about it. And I think that's why patients do better, is they ask questions. So it is an intervention. It's not an operation, but still has risks. That's number one. What was the second part?
The second part were how do you quote unquote qualify? It would be what are the parameters you're particularly looking for a patient that would be a good candidate?
So two things. You have to have emphysema. So people that are well versed with COPD, if you don't have emphysema, you're not going to be a candidate for this procedure. And you have to have enough emphysema in a lobe that makes it worthwhile to you that you don't need that lobe anymore. So you need at least 40 to 50% emphysematous destruction, so you won't miss that lobe's function once it's collapsed over. So you have to have emphysema, has to be in an area, and it has to be a complete fissure measured by either HRCT or physiologic characterization by measuring flow overall. So there can't be any leak with the other portions of the lung, because for the valves to work, they block the air going into a lobe, but let the air come out. But if there's a leak between the communications between the same lobes on the same lung, then that lobe will stay inflated even if the valves are in place, and it won't work. So you really have to have those anatomic things. And your chest has to be big. So you have to have hyperinflation, and that's measured in the hated phone booth from every emphysema patient, where they have to measure the lung volumes overall.
I hated it.
Complain about that more than any procedure, to be quite honest.
And so Jeannie also asked, if a patient is prone to respiratory infections, would you still be considered for the valves, and would valves potentially cut down on infections? I think it was kind of similar to a question that was asked earlier, but it's different enough that I figured we should include that.
If you have bronchiectasis and mucus hypersecretion in a lot of infections, I don't place valves in patients until I can do something that decreases their propensity for infection. And we've had several patients like that they may have non-tuberculous mycobacterium or MAC, or they might have aspergillus. We'll treat that first, and after that goes away and have that under control, then we would consider them for valve placement. So I would address those issues first.
Got it. So from Jim, Jim or Mary Nelson, what percentage of a lung is normally affected by the valves? In other words, how much, I guess that would vary from patient to patient. Is there a range you could possibly?
Yeah, so it's a lobe, and we have 5 lobes, 3 on the right and two on the left. So it's a lobar treatment. The more you can make that lobe collapse, the patient feels better because you'll have more of a reduction in the air trapping. So 100% atelectasis is the goal. That's achieved in about a third of the patient population. But a significant reduction is more than 350 mLs, and that's achieved in the trials in about 85% of the patient population. So in most patients, with appropriate treatment, you can get effective treatment that would improve your outcome about 85%.
Got it. Great. Okay, so Mary asks, if you have severe COPD and have pneumothorax, how likely are your lungs to heal from the pneumothorax?
Actually, this is the good and bad story. If you get a pneumothorax, it's temporarily sad news for the patient. The test tube is one. But the good news is those patients have the best function because it only happens if the lobe that you're treating totally collapses. And the reason why it occurs, you can't control the rate of the lobe collapsing. If the lobe collapses in minutes, that means the lobe on the same side that you did the treatment has to expand quickly. And the capability of that lobe to expand that rapidly exceeds its plasticity point, its give point overall. It may rupture, and that causes a pneumothorax, and you have to put the tube in. That usually heals in about 4 to 7 days. In some cases, though, not to keep the patient in the hospital longer, we'll send the patient home if the lung is up with the tube in place, and they'll go home for a week or two as an outpatient. Then we'll pull the tube as an outpatient. And that's what happened to Paul overall. Appropriate patients that are intelligent, that know how to manage things, can send the patient home and take it out as an outpatient.
Right. I mean, I'm sure that would have a lot to do with their, if we're going to use buzzwords, the social determinants of health would have a significant impact on the choice to do that or not. But so following up with that, actually, Jan had asked, I'm assuming she means the same thing. She says several previous pneumonos. I would assume that means she was pneumothorax. Does that hinder getting the procedure if that has happened before, if she's had pneumothorax before several times? Is that going to be a red flag potentially for moving forward?
So that's a good question, and that's a concern. That what type of emphasis that you have. If you have it throughout a whole lobe, or you just have it on the outside of the lungs, because those patients won't do well with a valve overall if it's only on the outside of the lung. And it depends on how the pneumothorax, when they had it, was treated. If they had a scarring procedure called fluorodesis, then that would increase the amount of scarring around the lung. And those patients that had a valve wouldn't have benefit, or basically would have a more complicated pneumothorax overall. So someone would have to, who's knowledgeable, would need to look at the case and determine what type of emphysema they have and what kind of therapy they receive when they treat.
Yeah, got it. And I know some of these questions are really impossible to answer without actually knowing a complete history on the patient. So no, it's excellent answer. So and Mike also asks, what is the reason for so many different cases of deflation of the lobe, and why do some lobes just don't deflate after the procedure, even though there is not evidence of a collateral ventilation? I'm just reading exactly from his question. Is that you follow that?
I do.
Okay,
so, there's a couple of reasons for that. First of all, the valves have to be pretty much in good position. And good position means that they're called the segment, that portion of the lobe, and they need to be in place, and they need to completely block that area that they're in. Sometimes with respiration and the heart is beating, those valves can rotate slightly. It may go a little bit further out into the lung and expose an accessory airway, and the lobe may reinflate. And patients might need an adjustment or a repeat procedure just to focus on those problem valves. And that happens about 20% of the time, that people might have to go back and have a, quote, valve tune-up to fix that. And one of the reasons, and even if the valves are in place and there's no collateral ventilation, that it may go down, may not go down, is if there's a lot of scarring around the lobe from prior exacerbations that you can't even see on X-ray. And that may keep the valve, the lobe from reducing, even if the valves are in appropriate position. So in those cases, and we've had them, maybe about 5% of the patients that we've done, that the lobe doesn't go down, patient will go on to surgery, and the surgeon will release the adhesions and will surgically resect the emphysematous tissue with a good response. So it's, again, pursuing the target to make the patient better, which is trying to deflate the patient when you're trying to do a volume reduction. No matter what procedure needs to be done, it's to try to achieve that goal.
There we go. And then Mike also asked why sometimes some patients get different amounts of valves. I had 5 in the upper lobe, while I know several cases where 3 or 4 used in the same lobe.
Yeah. So the range overall is about 3 3/4 valves throughout all the studies. Lower lobes will require more valves than upper lobes, especially the right upper lobe usually only requires 3. But a lot of it depends on the patient's anatomy. If they have a big lobe or multiple airways, it may not allow just 3 valves or 4 valves to be used, which is the mean overall. So it depends on the individual patient.
Is there an age limit, say 76 or 77?
Age isn't a factor. If you look at other comorbid conditions overall, there has to be some realistic options to this. But we've done people in the early 80s who were medically fit to undergo a procedure and handle a complication if it occurred on a case-by-case basis.
Yeah, absolutely. Yeah, I am a firm believer that yes, age does have an effect, but there's I know several folks that are in their mid 80s that you would swear they were, maybe in their later 60s. So
yeah,
it can change. So another one popped up. So Dr. Kreiner, do you does a doctor? So Patty's asking, does a doctor have to tell me how many valve procedures they have done and their success rate? In other words, if she asks how many have, if she's going to a physician, how many have you done and what's your success rate? I mean, does the doctor have to answer that question?
Well, I think he should. I mean, you have every right to know. I mean, who you're going to, how much experience they have, and something like this, like in most cases, experience does matter because you know how to optimize the procedure, choose the right subject, choose the right area to treat. But more importantly, if there's a complication that develops, be experienced enough to know how to handle it.
So here's so a question from Jeannie. Can you place valves in a lobe that has already been surgically reduced? No,
that wouldn't be something that you'd want to do, and you wouldn't really have the need to do it if they've already had surgery. Right. I would look for something else as the target for the patient's breathlessness rather than doing more lung reduction.
Right. Got it. Good question. Excellent. So I have a question for Paul and Ronnie and Leslie, if you guys don't mind. So and maybe this is a little redundant, and because I know, I guess, Paul, you mentioned one of the things that you really wanted to be able to do was to be able to garden again. Right. But was that was that the driving factor behind your choice to try to move forward, or did you, and I'm going to kind of pose this question to all of you, was there one driving factor that really made you guys want to push forward, or was it just the fact that for goodness sakes, you just wanted to feel better, and this just seemed like a great way to do it.
You hit the nail right on the head. All I want to do is feel better and to do normal things. I don't want to go out and lift weights or try and play football again or whatever. What I want to do is be able to mow my grass, my own grass, trim and blow it, and work in my gardens and set up displays at Halloween and Christmas. That's all I want to do. If I can do those things, I'm going to be a happy man.
Excellent. Excellent. Ronnie?
It was just, you just want to have a more quality of life. Like prior to having the valves, I mean, just even going to the store was it took so much energy out of you. And now you can just go do some things like that. And prior to COVID-19, I used to go back and forth on a train to Connecticut. Like I said, I go work out and I go visit my relatives. And doing them things before just took so much effort. And now, I'm not Michael Jordan or anything where I can get around slipping. And I can still take my time.
Oh, that's good.
But you notice the difference because I know where I was at before. And I'm just so thankful where I'm at today. And I don't have to make sense of not here for you, but it's just a big thing for me. It's a huge thing for me.
Excellent. Leslie, how about you?
I really wanted to do everything I could do to be around and to be able to participate in life. Like it was my family, I think, was my biggest driver. I couldn't live with having the opportunity come by and not really looking into it, really taking it seriously and trying it if I qualified. And I'm just so grateful that I did. Because it's made a big difference. It gives you confidence. It's just like COPD is like such a crappy situation because psychologically it just wears on you so much. So once I got the valves, I really felt like I owed something back. It's like I really had to start taking better care of myself, doing everything that I was supposed to do. So it gave me a motivation in a sense. And surely being able to experience a reward, like being able to do more things with my family and my kids and grandkids, even encourages you more to keep moving when you don't feel like it, walking if you don't feel like it,
Yeah.
Because after all, we're getting older. This is the last time.
No.
This is not an ideal time to take up exercise. Right?
You're
you
right.
kind of have to.
Yeah. So, now we have a couple more questions that popped in, and we're coming towards the end of our time here too. So, Patty asks if emphysema is evenly spread throughout my lungs, and I have an FEV1 of 20%, could I still be a candidate? And then she says, "Last question, LOL."
Well, there was one small study that looked at that and showed you could improve lung function for at least 6 months in people that had diffuse emphysema. But overall, with lung reduction, whether it's surgery or a valve or a coil or a glue, if you have even distribution of emphysema and your lung function is 20%, the effect isn't that great and it doesn't last that long. So what I do, we'll look at the patient and talk to them about that and make a determination whether it's worth it to them to undergo this, knowing the things I just said, or would something else like a transplant be a more effective option?
Got it. So, and Mary just said, I want that question too. Okay, well, that's good. We got a 2-for-1 on that one. Excellent. And Jan says, you guys are an inspiration, and I'm sure she means the patients. I'm sure you are too, Dr. Kreiner. But
I mean the patients.
Yeah. Now, some of the most amazing people I have met in my life have been thanks to being a small part of this whole COPD community. So my admiration for all of you on this call is immense because it's just again, some of the most amazing people I've met have been folks like all of you. So
Thank you, Joe.
Thank you.
mean it. So a couple last little messages. It's an excellent program. Thanks to all from Jeannie, and then thank you from Mary. And whoops. And actually, it came up as me, but I think that was Michelle typing. Thank you for attending. Although I meant that too. So again, I do want to say thank you to everyone for joining. Dr. Kreiner, thank you so much for your time. And especially Paul, Leslie, Ronnie, thank you for sharing your stories and thank you for your time.
For sure.
Love it.
Greatly appreciate it. And good Lord willing, Dr. Kreiner, we'll see you at the old COPD next year when we're actually in person again, I hope.
That'll be great. That'll be great.
Right.
Thank you all. Thank you, Dr. Kreiner.
Thank you,
Bye-bye.
Dr. Kreiner.
Bye, everybody.
Thank you, everyone.
Have a good night, guys.
All right.
Thank you.
Bye-bye.
Leslie,
Thanks.
Ronnie,
Take care.
Joe,
Yeah.
Julia.
Thank you, Paul.
Thank you,
Bye.
Paul.
Thank you.
everybody.
Thank
Thank
all
you.
patients.
Thank you, Julia.
Love you all.
Thank you so much,
Love
Ronnie.
you too.
Thank you, Leslie.
Thank you,
So
Paige.
welcome. Thank you for including us.
Of course.
Thank you, Joel. Thank you, John.
Thank you.
Thank you.
All right, guys.
Thank you.
All right.
Bye-bye.
All right, bye-bye.
Thanks,
Bye-bye.
guys.
Bye, everyone. Thank you.
All right, bye-bye.
Bye-bye. Thank you.
Guys, hot lasagna. And to
Okay.
you.
Check out Lung Valves for Friends Facebook.
Yeah, good idea.
That's a good site.
Excellent. All right, guys. We will see you all soon.
All right.
Have a great night.
Are you ending the recording or are we just all going away?
Well, we are stopping the recording and then